Good afternoon, everybody. Welcome to Department of Healthcare Access Information's webinar on the California Rural Health Transformation, Workforce Development, Recruitment, Retention. I'm just going to give everyone about 30 more seconds to log in. I know there's quite a few attendees, so I want to give everyone enough time to get in and troubleshoot anything through Zoom. I'll start in about 30 seconds. Okay, I think we're at the point. I think we just about everyone's in. I see a few more folks coming in. So I'll start. I'll start with some logistics and some intros. So welcome everyone. My name is Hovik Kosrovian. I'm with the Department of Healthcare Access Information, Senior Policy Advisor for Workforce Development. Really excited about bringing this webinar to everyone. I'd like to call it the event of the year to bring this all to you because it's highly anticipated. But it's really exciting to have this opportunity to bring it all and discuss our rural health transformation intents for the workforce, particularly this grant opportunity, the intent around it, the framing, the structuring of the grants themselves, and how to best support everyone here in applying for the grant funding. Some initial logistics, just to get everyone kind of centered on using Zoom. So the chat is not active in this webinar. There is a Q&A, so if everyone has access to it, you should be able to see it either on the bottom or if you click on more, you'll be able to access the Q&A. Feel free to add your questions as we go through the slides today. I will answer them, and our team will answer them to the best of our ability at the end of the slides. Fortunately, we have not too many slides, so we'll be able to have ample time for addressing all the questions that you all have. One thing I will kind of really queue up as well is any questions that are very, very specific related to like terms and conditions of the grant or the grant agreement. Please, you'll see an email address at the end of this webinar, and you'll probably see it linked in a little bit. Please direct those questions to our mailbox for California Rural Health Transformation. You'll get much more specific responses there rather than in this webinar. Our intent really is to provide guidance and questions on some of the more broad technical aspects of the grant. And anything very, very specific, we might defer to discussing offline or having you reach out to us directly. So with that, I'll kick it off. So again, thank you again for all of you joining us today. Really excited about this opportunity. I will walk through the overall program. I'm sure many of you have probably heard this, the overview of our California Rural Health Transformation already, but it's always great to kind of reiterate what we're focused on and how it all aligns. Then I'll go over our Workforce Development, Recruitment, Retention Grant. You'll see the acronym that we've put together for WDRR. As many of you probably know, we love acronyms. And then I'll go over the funding and eligibility and uses, and then key dates and resources to really support everyone here and putting forward the best application possible. And to really, again, to reiterate, this is one of those big opportunities that we feel really strongly about to enable rural communities to have the services they need in healthcare and to be able to support the facilities that deliver those services to have the workforce they need. So this is a really key initiative in the broader scope of rollout transformation to really stabilize the workforce, support it as we continue our other grant opportunities and go into year two of rural health transformation and really expand how we're going to help, again, using that word, transform rural health. So it's really excited about this. So go to the next slide, please. So we talk about rural health transformation. I'm sure many of you have probably seen this slide already, but really wanted to reiterate here again the key goals and objectives of rural transformation. There's three main, you could call them initiatives, pillars. Really centered around one is that transformative care. Many of you, we had a webinar a couple weeks ago on the transformative care and accelerator partners. That is really focused around building those rural and regional collaboratives to support the opportunity for all rural Californians to be able to access healthcare as close to home as possible with specific services. Again, we're focused on our rural health transformation. We're focused on primary and maternal care, as well as addressing specialty needs. And that's where those rural and regional collaboratives come in. And that's where our first pillar of transformative care is really building on those models to support the overall structure of rural health delivery. What comes in next is the workforce component, really what we're going to talk about today with our grant. And this is where we talk about what do those organizations need? What do those collaboratives need? What do rural communities need to really address their health workforce needs? It was a key issue identified in our outreach that we did as we developed the Rural Health Transformation Grant Program. Uh, and it's one of the key structural components of how we can transform rural health. And then third, and it's something that we won't discuss today, but there was a webinar and there's much more information online about our technology and tools and how that then supports the overall structure again with things like electronic health record modernization, e-consult, telehealth, remote patient monitoring, many opportunities for organizations and communities to really build up the technology to really sustain and continue the transformative efforts of the overall program. And with that, many of you might be aware as well, we received 233 million from the Center for Medicare and Medicaid Services for rural health transformation. Really excited about that. And again, we've probably mentioned many times in other previous sessions where it's a very tight time frame. So we're very excited to get this out now and give enough opportunity for everyone to apply and get those funds out as quickly as possible for everybody so we can start working on addressing all these needs in rural communities. Next slide. So today we're going to talk about the Workforce Development Grant, the recruitment retention, but I just want to really highlight there's two other opportunities that are currently open now. And there's also a webinar that happened. I believe it should be on our website, the recording, the Accelerator Partners Grant, which is an open opportunity now to really help build those rural collaboratives around our key goals and metrics around rural health transformation. There's also the EHR modernization grants available right now to, again, like I mentioned earlier, to really support the upgrading of interoperability tools, electronic health records, telehealth, and e-consult. And today, we're talking about the workforce development. So if many of you have seen through our previous presentations or our materials on our website talking about workforce development is kind of that key component to ensure structurally this transformation is sound and sustainable. Without workforce development, many of you know, if you don't have the workforce, you can't provide the services, you cannot bill, and it's just a chain reaction of events that really makes everyone struggle to ensure there's access. So workforce development is that key pathway we're developing right now. This is the first step. Recruitment retention grant is that initial step within the time frame we have now, this year one, to ensure that we have the structures in place, we have the workforce that we need. So in year 2 through 5, we can then work on developing the educational pathways, the pipelines, the clinical training, and recruitment retention support. So really, this is the first kind of key component to stabilizing what's needed in the communities as we develop more long-term sustainable approaches like pathway development, like training opportunities and education, which is really the key long-term solution to many of the workforce issues. So with that, we're going to talk about the grant. Just want to highlight there's 54 million available for this grant, and we project an oversubscription, so we most likely is going to be a very competitive grant application. With that, I want to now discuss kind of the goals of the program, and these are really centered around what we proposed to CMS around overall rural health transformation, but also specifically on the workforce goals. And this is again focusing on primary care and maternal health teams, this iteration of this program as the initial support structure to build out all our other components and to really build out the infrastructure of rural health. So we want to reduce vacancy rates. So we're hoping this program really supports that in helping you retain providers, helping you recruit providers, reducing the number of time to fill for many of these positions. I know in rural communities it's very difficult to fill certain positions, to have people continue to work there. So we're really hoping to develop that ability with this first round of funding. We want to improve continuity of care. Of course, we all know if you have the providers available, you have them accessible to the communities, that really is going to improve the long-term care of the individual, have the coordination between the different teams, whether it's primary care, maternal, specialty care, having that coordination and having the support, not just the advanced practitioners, but really having the support staff there as well to help them really ensures a much more sustainable structure. Third is that recruitment retention of health professionals. So we talk about this. I mean, it can't get more direct than offering retention and recruitment bonuses. So one of the goals again is to offer those bonuses to help get providers there and keep them there. And then lastly, again, what really helps overall structurally is that is as we build out and hit those other goals, is now we're having a really supporting a responsive and sustainable workforce, which is the ultimate goal. We don't want this to be just a fly by night one time. Here's some funds, a few years from now, we hope it worked, but there we just, there's it's not that kind of program that we're developing with rural health transformation. This is much more of a long-term sustainable approach, and this is that first kind of key pillar for getting things stabilized, so that we can then take opportunities elsewhere around workforce and health delivery in general to really support the structure. Next slide. So really bringing up first, it's always we always start with what you can and can't do with the funds to kind of get that out of the way. Then we can talk about more of the the fun stuff about the types of providers and what really the kind of intent is. But really wanted to bring this up front. I won't go through the entire list of all the allowable and unallowable uses. That's also identified in our grant guide. If you have an opportunity to read through the grant guide, we have the links available. They'll be posted soon if they're not yet, as well as it's already on our website. But just want to highlight a few areas. So again, allowable, really this program is specifically focused on offering recruitment bonuses and retention bonuses to health professionals. That does require a 5-year service obligation that is directly through the grant itself. It's required not just as part of the grant we received from CMS, but it's actually in law. It was part of the bill that passed last past summer to really create the rural health transformation program. And there's a lot of other, of course, we always talk about there's a lot of negative things that came out of that bill, but this is kind of that one silver lining to really support rural health. So the one requirement, you'll see it's steadfast. There's no exceptions. There's no changes. Is the 5-year service requirement for individuals receiving these bonuses. Now, we also want to highlight there's opportunities here. You can really focus on building out clinical capacity, and we talked about kind of like the long-term goals of rural transformation. One of the things on workforce is we want to be able to incorporate and address some of the clinical training bottlenecks that we see. Many facilities don't have the resources to offer those services or don't have the opportunity and the structure in place. So we're hoping these funds, if it's feasible, to use them as kind of building up the faculty. So whether use bonuses for to support preceptors participating in training, other uses, but really the focus is again using these bonuses. We wanted to give clear flexibility to organizations to use them for their needs with just certain parameters that are just really required by the grant itself through CMS and through us to really set up the structure for future years as well. So it's we open it. So one thing we would do, I get asked quite a bit, and it's probably on top of everyone's mind, is indirect costs and admin costs. So indirect costs are not allowed in this program. We have what we call program costs. So that is defined as costs for anything that is required to support the implementation and oversight of this award to your organization. So up to 10% of the award can be used for that itself. So it could be used for, staff time. It could be used for coordinating. It's flexible on how you want to use those program costs, as long as the focus and intent is to support the actual implementation and administration of this fund at your facility or organization. There's much more details in the grant guide on that. Unallowable cost, it's something that it's probably many things that many of you are familiar with, nothing probably new or life altering. Many requirements that you've probably seen in federal grants and state grants. Things where as far as no pre-award costs can be incurred. Obviously, there's no capital improvement funding that can be used for this as well. And then there's a few other things that are much more detailed and described in the grant guide as well. But I want to be able to just highlight that and have folks, if they have a chance, to go through and look at these. But happy to, these are much more specific questions, probably too, if you have any. If there are any general ones, we'll try to answer them at the end. Anything specific, again, just please refer to our CalRHT mailbox for much more of those really specific questions on cost, because we know there's a lot of unique situations across the board. Not everyone's going to have the same question or same specific response. Next slide. So the structure and funding availability for the program overall, there's total of 54.17 million. That was the structure of this first year budget funding. We have a maximum award per facility and then a separate amount per consortium, collaborative, or system. So the 1 million per facility, I think that's pretty self-explanatory. If you're an organization, whether it's a hospital, community health clinic, a rural clinic, a tribal program, other comprehensive health facility. Per facility, the cap is 1 million as you apply. You select the provider types you want to award retention or recruitment bonuses to. There's a maximum for each provider type, and as you total up, each facility that applies has that maximum. Now, if you're applying as a collaborative, a consortium, or a system, that is increased to 2 million. Whether, there might be questions on if I'm a large system, do I apply individually or together? We'll answer that at the end, but just know it's really flexible and up to you on how you want to apply. Uh, for the future cycle, so as these awards, as we build out these awards and award them to organizations, there will be future cycles of this award. And as long as, so individuals that receive these awards can apply again in future years, as long as you're not using them for the same staff. You're using them for different health professionals. You're not using them for the exact same ones because we can't double up obligations. So it is open to individuals that receive this award this year to apply again with the notion that you understand that you're applying for other health professionals, not the same ones that have already been awarded. The application award timeline, again, really want to highlight this. It's open now. It opened Friday. It closes on August 31st. And our goal, again, given the parameters around the obligating of these funds and awarding of these funds, we're looking to execute the grant agreements by September and October of this year, so folks can have the opportunity to use those funds appropriately and get them out to their providers in due time. Next slide. So going over some of the eligibility, again, it's a long list, and it's not comprehensive on here. I recommend everyone look at the grant guide for the full list, but really want to highlight, again, the focus here is to get the funds into the rural communities, to get them squarely into those communities that need the support the most. So our eligibility obviously would be rural hospitals, critical access hospitals, FQHCs, lookalikes, rural health clinics, tribal clinics and tribal health programs, and other community clinics, consortiums, collaboratives, healthcare districts, and much, much more. So really, you can see the focus here is we want to get these funds directly to the organizations that are providing these services in those rural communities. As far as rural definition, so one of the parameters, and I described earlier, the 5-year obligation, one of the requirements is that the health professionals that receive these awards, these bonuses, as well as the services they're providing, have to be in a rural area, a rural designated area. We are using the Health Resources and Services Administration definition of rural. It's also, Federal Office of Rural Health Policy is kind of the sub division within the department that oversees this. There is a link. I will say it's a very expansive definition. It's not perfect, but it covers much more territory, California than it's beneficial to the state to have this definition because it covers quite a wide breadth of territory, California. So about 82% of the state is considered rural through this definition, which is great because it actually helped us in our application as well to receive the funding we did through the rural transformation. So that is the definition we're using. Again, you have the services and the provider have to be in this rural setting. It cannot be outside of a rural setting where they're providing services. There again, repeating, there is one application per organization or regional collaboration consortium. And just keep that in mind as you apply. If you have multiple sites, think about how you want to apply. But it would be one application per organization or site, as you can look at it that way. So what's not eligible, really wanted to kind of address this. So temporary staffing agencies, management services, and applicants that are either disbarred, suspended, or have findings against them from federal assistance programs are not eligible. We want to make sure this funding is going to the community, is going to the individuals that need it the most in the communities that really need this support and this workforce. So that is why we have that list of non-eligible as well. So next slide. So we're going to go over the scoring a little bit here. As we talk about the scoring, so we suspect that this is going to be oversubscribed. So we really wanted to identify the most in need organizations and communities for these funds. So what we focused here is about six criteria that really are focused on addressing the needs of that organization and how you're doing it and who you're serving, what your organizational kind of structure is. So that really aligns with identifying the priorities of rural health transformation and directing those funds to these organizations. So first one you'll see is we want to give additional points for organizations that offer services in the indigenous or tribal language. We really know one of the key components in rural communities is the tribal health programs. So we want to identify and support them. and ensure that they are receiving the services they need because of just the significant need of services they have already. Uh, Second is payer mix. If you're familiar with our workforce development programs, you've probably seen this in many of our other grant programs. Payer mix is a key component. Organizations that are applying will be looked at as far as the percentage of their payer mix. So organizations with higher Medi-Cal, Medi-Medi, and IHS services will receive higher points. Organization type is another one. So if you're one of the priority organizations that's listed in our grant guide, you'll receive additional points as well. We really want to support the collaborative and consortium model. We know a number of communities, one individual facility might have difficulty recruiting a provider just because the service level is not there, but there's a need for the community. So we really want to support these collaborative and shared workforce models. So organizations work partnering together to bring in whether it's a specialist or specific type of health professional that they need, and ensuring that professional is able to work at the top of their scope, is able to get their hours they need to continue to be, successful. So we're really looking at if you're applying as a consortium collaborative or having this shared workforce model applying as a group of facilities, that's really a benefit to you and that will receive additional points as well. Fifth factor is that additional, priority professions. So we talked about primary and maternal health being our key priorities here. Doesn't mean that that's the only individuals that might get awarded, depending on the number of applicants we get, depending on if how many of those only focus on priority professions. Others might get awarded as well that are not the priority, secondary priorities. But again, depending on when you apply, if a majority of your funds are going to be used for these priority professions, you'll get additional points. And lastly, if you have plans to use any of these funds to really expand your clinical training faculty or preceptor capacity, that's something that, again, I talked about. We really want to help kind of set the structure in place for future years when we expand more of the educational opportunities in these communities, as well as the training opportunities, be able to have organizations prepared and ready to go when these grants come up so that you can then take advantage of additional funding to support that. So those are the key components of our scoring criteria. Next slide. So here's a list of the priority professions. Again, I won't say this is an exhaustive list. I'm sure there's individuals in here that aren't called out. Our grant guide has much more in-depth list of where we are on the provider type. So again, it also has qualifiers of like other allied or support health professionals, but really just wanted to kind of get this out in front of everybody to kind of address the key priorities that we identified in these professions. So there's maternity care, which again, we talk about the full maternity care team, whether it is an OBGYN, a family medicine doc, then midwifery, doulas, lactation consultants, we also incorporate your medical assistants, nurses. So they're all part of that team. So that's the maternity care team that when we hear that, that's what we refer to. So that's one priority. Second is primary care is another priority. Again, the full team from physician all the way to medical assistant. Nurses are also a priority. So registered nurses, LVNs, particularly those that work on a primary care maternity care team. Those will be a priority as well. And then we have our more expansive, whether you want to call them allied health professionals, support staff. This is the community health workers, promoters, representatives that support those facilities, as well as other allied health professionals that are part of the primary maternal team. We know there's a much longer list than probably we can spell out completely, so we wanted to give it flexibility there for folks when they apply to list out what they need, and then we can work with them to identify if that's one of the priority professions. Next slide. So just kind of give everyone an idea of like what we look for in the application. So we try to make this, again, we really wanted to make this simple. It's a program that we really wanted to keep effective for everyone. We didn't want to have a complicated grant process where you give us a project narrative, like a full-on like a work plan and key supports. So many of you are familiar with those grants. We wanted to make this simple as possible because we want to make it available to all programs, whether they're large or small. And we know many small programs have challenges around resources to really apply for many grants. So the key here is that, and you saw there was a scoring criteria, it's data driven. We're really focused on using data to help guide us on the needs of the community and where to appropriately fund these grants. But application itself would include, are you looking at expanding training capacity? And this is where we refer back to if you're part of a collaborative consortium, it's really great to see like, do you have the intent to use any of these funds to build out your training capacity by, again, incentivizing preceptors and faculty support or other means. Are you supporting priority professions? Again, when we referenced like this, the list you saw earlier, as you apply, you'll be listing out which professions you want to provide retention or recruitment grants to. Those will really key in on the successful application if you're focused on priority professions. Again, you saw with the metrics, the collaborative and shared workforce model is key as well. So if you're multiple organizations working together in that region or that community to really support this, that's great to see as well, and that's something that we really want to see in the applications. And then lastly, the alignment across the metrics. So you saw the metrics earlier where we're trying to really resolve time to hire, vacancy rates, time to fill, access for individuals for many of these services. So how do you align with that metric? That's really the goal here as well. So knowing where the needs are and seeing that you're looking to recruit and retain providers that fill those needs is a really key for a successful application. Next slide. So some reminders around the Rural Health Transformation grant guide here for workforce development, recruitment, retention. Uh, we do have a grant guide here, so really that like there's a lot of answers there in the questions. So when we finish here, we'll try to answer as many questions as possible. So you might see us occasionally point to the grant guide because it probably can give a better response than I could possibly. It's be much more detailed. So really want to really recommend everyone, if haven't had a chance yet, to really look at our grant guide and the materials on our website and the application portal. So once the application closed on 31st, we'll be evaluating those applications, scoring them, reviewing them, and we also are going to look at ensuring that there's equitable distribution of the funds as well. So that's one of the things that we always kind of bring up when we do our workforce awards is we want to make sure that folks that need it get it, but also that we're not we have the opportunity for folks that necessarily might not get these kind of opportunities to have that grant. So we are looking at not just pure scoring, but there's also parameters around the equitable distribution of the funds to communities that need it. Next slide. So additional research, like I mentioned earlier, there's our website, our CalRHT webpage that has the grant guide, budget template, work plan, and then any FAQs in the portal as well. And this recording will be posted there shortly after we finish today, in case anyone missed it or anyone wants to go back and hear any of the kind of the responses to some of the questions. And of course, really recommend our email address here at info@calruralhealth.org. If there's any questions, particularly if there's very specific, nuanced questions that might not be relevant to others or might be, it might take be a little more challenging to answer during a webinar, please we ask you to email that info at Rural Health to get much more detailed response that's much more targeted to your question. Next slide. And yeah, and that's it. So now I think we're going to be able to open it up for the questions. I'm sure there's probably plenty of questions. I think I see quite a few in there already. So I just want to give everyone an opportunity to post some of those questions. I believe some of them have already been answered if they're pretty, straightforward and simple enough. I think that the team's been answering some of those early initial questions, but I know there's a few that we kind of have to start with. So let me bring that up and start going through these questions. Let's see. So first question, let's see. Expand on eligible sites. Is mobile care and telehealth considered rural? So mobile and telehealth is allowed under this obligation. However, the services that are provided under telehealth or mobile must be in a rural community. So it must be one of those rural areas that we identified earlier through that HRSA link. So they have to be taking place in those, and that's based on census tracts. So you can give someone a retention or recruitment grant if their primary role is to be in a mobile clinic or telehealth. Those services have to be in a rural setting anyway, like they physically have to be located in a rural community, but they also have to be all their services, all the patients they see have to be from a rural community. So it's allowable. It will be something that the organization does have to track and verify that all their patients are from rural communities. So look at the second question here. The application says in the allowable use of funds, funding must flow through eligible healthcare professional bonuses or allowable program cost coordination. You want to clarify, can the budget application include funding for retention and recruitment training? Or is the expectation that all funds used for recruitment and retention bonus? It's a long question, minus 10%. So the recruitment retention bonuses, there's flexibility. So I'm trying to think like more specifically here. So you're talking about offering bonuses for folks that are going to train at your facilities. I think that's maybe what you're maybe I think that's what the questions were alluding to. If not, please, add more into the Q&A if you can. Um, so because a training doesn't necessarily mean that they work there, so the individual that's going to get the retention and recruitment bonus has to be an employee or work in that facility. Again, employee is flexible, I understand, because some hospitals, they aren't able to hire directly for physicians. But they have to be physically working full time in that location. So that's the requirement. So if it's related to training, that might be something that you want to send. Maybe if you want to send us a more direct email to the info to address it. Necessarily, it can't be offered as like a bonus for someone that's going to be like doing their clinical training there. So that if that helps answer it, that's for sure. It can't be a bonus for someone going through training. It has to be an actual licensed professional or certified, or it could be a non-certified if it's someone like a CHW or a doula. But it actually has to be a health professional providing services and not someone that's in a training program or educational program. Uh, the 10% is flexible, so that's where you can do some things if you want to decide if you want to use it for your admin cost, if you want to use it for building up some of your training capacity. That's a little more flexible, and you can describe that in the application. But as far as the direct bonus payments to individuals, that has to be a health professional that's practicing, that's available to currently practice unrestricted. The next question I see is how does a service obligation work? So it's a 5-year service obligation. If you've seen it in the grant, I'll highlight it here. We're saying so this kind of connects to probably some other questions about like recruitment of funds, things like that. Uh, so we are in our grant guide, we are stipulating that the bonuses be paid in arrears, specifically because if you're paid in advance and the provider leaves, that funding is owed back to us and then ultimately to CMS. So we didn't want to have or organizations, particularly smaller ones, at risk of potentially having to recoup large amounts of funding from someone that no longer works there. So the service obligation is 5 years, paid in arrears. With the one exception for a recruitment bonus, we understand that could be sometimes used for relocation. So that you have the ability in the year one to do an upfront payment to support their move. After that, it would be in arrears, and it's really to really help support those organizations and not having to have the risk of all of a sudden having to pay back if someone leaves. If it's paid in arrears, you would give someone the bonus for that year divided by 5. If they have served that full year, if someone leaves like halfway through, then you haven't paid them and you don't have to recoup any of those funds. So it's really about ensuring that there's the least amount of risk here because those funds are, if they're paid in advance, would have to be recouped if someone left. So again, obligation, it's outlined in the grant guide and grant agreement, but once an organization receives the awards, they would go into an agreement with the employee over the obligation and the terms for that obligation. And we have that outlined in our grant guide as well. So fourth question, can an organization participate in more than one consortium under the Workforce Development Recruitment Retention Program, provided that health professionals receiving recruitment bonuses do not overlap between consortiums? Yes. So if you have a consortium in a community, let's say example, you want to bring in more midwives to your facility and you're part of that consortium. You can use the funds for that. And then if you're in a different region or a different community or a separate consortium that's completely different, focused on some other kind of care, you participate in that as long as it's not the exact same site receiving the exact same funding for the same professionals. Organizations can apply through multiple consortiums. Just focus on what you're working on and not overlapping with the previous ones again, and not having the same sites with the same providers. So how many awards are available? Is there maximum funding? So that one, yes, that one was answered in the slide deck. It's $1 million per organization or facility, $2 million if it's an organization, if it's a consortium or collaborative or system. If you're applying for multiple sites, that's kind of looked at as a system. If you're applying one site at a time, that's that 1 million cap. So 1 million for individual organizations, 2 million for those consortium systems and collaboratives. How many awards are available? Is there a maximum funding amount per organization and per retained provider? So I think that's my answer, right? Yeah. Sorry about that. Are organizations outside of California eligible to apply? So the organization applying has to be in California and has to be the organization, whether let's say it's a collaborative, the organizations within that collaborative must be providing services in California in rural communities. The organization, if it's individual organization applying, must be located in California, providing services in the community, and those providers must be providing services in those rural communities. So I guess the technical answer is if it's an outside organization, which it really shouldn't come up, I believe, because these are organizations that are applying are physically providing services in those rural communities. Now, if it's a large system that has a headquarters outside the state, that's a little different. We expect for those organizations and systems, they would apply based on that site or that facility, and not necessarily apply through a corporate, outside entity. But that could be if that's a unique situation. Please email us. We can talk offline and kind of understand more of that question too. Number seven, does the service agreement have to be filled at the hiring clinic or in rural areas in general? So this comes back to if you're applying as an individual organization. So obviously, if you're applying as like let's say one hospital or one clinic, then that individual providing those services would have to be at that specific setting because that's how you applied. If you're applying as a system, a collaborative, or a consortium, then you can share the services. That would be up to how the consortium or collaborative is set up and how the shared workforce model is set up within your organization. So that's something that, that's not our forte. So if organizations that have those collaboratives have MOUs or whatever it might be, it's up to them to kind of build out how they want to do that workforce sharing model and how they want to come to agreement on how the obligation is met and tracked. So, but yes, they can go across multiple sites if it's like a consortium or if it's a system applying and they listed out those sites in the application. Um, will providers who advance into different roles still receive funds? So it's a good question. That's something that it's one of the ones I think we initially kind of were thinking of how to address. So if it's a provider that moves from, let's say, like an entry-level role to advanced role, uh, if they're still providing service at that location and it's one of the priority professions, I would say yes. That's the initial thought. This might be one of the ones where if it does happen, we'd like to have you kind of contact us if you're a grantee to identify what role they're advancing to, if they're still working the same location, what is their new profession. So generally, yes, if it's, let's give an example, if it's a medical assistant who becomes an RN, if they're in the same location, if they're working and focused on primary maternal health, great. We don't want to limit that. We want to be able to have people move through their career. But again, it's probably more nuanced than that and depends on, if it's a completely different profession that was not part of like our priorities or not part of the original application, it would factor in. So if that does happen, yeah, we definitely would ask the grantee to contact us to let us know so we can give them a much more detailed response. But generally, we are supportive if it still meets and aligns with the rural health transformation goals. So number nine, next question. Can you clarify what you mean when you say expanding clinical training? Is this referring to growing residency programs or offering additional training opportunities to clinical providers to cultural sensory training constitute? So when we talk about clinical training, we understand many facilities have them. Others just don't have the infrastructure set up to offer them. So we're talking about non-physician clinical training. So we're talking about RN training, LVN, midwifery, whether it's medical assistants, other support staff, or allied health professionals. So we're talking about the full scope of just about everyone that's not a physician. I guess that's probably the best way to say it. So we want to really focus on expanding the training capacity for that because one of the opportunities we're going to have in future years is expanding educational programs in those professions, as well as funding students to go into those professions and create pathways and pipelines. So we want to make sure that the training capacity is there in these facilities in these rural communities, because one of and it's probably you all are very familiar with this. Where someone trains is generally where they stay. So if we're able to really address this is the long-term really solution of if we're able to increase this clinical capacity, training capacity at the facilities using funding from rural health transformation, and then we bring in students that we've supported and education programs that we've expanded, that really creates that pathway of ensuring students from those communities have the opportunities, also have the training available. It helps resource the facilities by having those training opportunities as well. In the long term, it's very beneficial. So when we talk about training opportunities, it's actual clinical training. So it's training that's connected to whether it's their hours for licensure, hours for graduating from their degree program, or hours for certification or other types of programs like doulas and CHWs and medical assistants too. So it's more about the specific training and not so much training as like a broad concept of like different modules that you want to introduce. So next question. For rural areas, I see the HRSA requirements. This RFE are counties that are considered not fully rural and eligible. No. So good question. So HRSA does have this definition of rural county, partially rural. We're looking at the census tract level. So there is on that website, if you use it, it does look at your direct census tract. Any of you that are savvy with Excel or any other tools like that, there's actually a full Excel sheet list. But we'll also have, so if you put in your address on that rural tracker, it'll tell you if your census tract is in a rural community. So you don't have to be a fully rural county. One example, and many of you probably know, is like Fresno County. It has an urban center, but extremely rural everywhere else. And that the Herster definition is like a partially rural. But when we're talking about rural, we're talking about the communities themselves, the census tracts that are outside those urban settings. So it does not have to be a full county rural. It could be based on specific community level. Next question. So does a qualifying application need to include recruitment or retention bonuses, or can the application focus on collaborative activities that do not include bonuses, such as focusing on preceptor capacity and shared staffing pools? So application does, it's solely focused on recruitment retention bonuses. Now you can use those bonuses to do some of the work like preceptor capacity by supporting preceptors or encouraging, folks to become preceptors through those bonuses. But it has to be all kind of focused and squared around offering retention and recruitment bonuses. Now that 10% that we talk about program cost, that's where the flexibility lies. If you do want to expand training by, let's say, like, expanding the capacity for whether it's a location, whether you need certain equipment or tools, that's where that, again, when I say equipment tools, that's probably a little more nuanced because we have to like, know what you're going to spend it on. But that 10% could be focused around expanding your actual infrastructure for capacity for training. But the grant itself, when you apply, the funding is, minus the 10% is specifically for bonuses. And how you define that, whether, again, like I said, if you want to use that to give a bonus to a faculty member to come to do training at your site, that's great. That could be used for that. Preceptor bonuses as well. We're just kind of broadly calling them retention and recruitment bonuses, but it does have to be a bonus itself. It can't be anything else besides that. It can't be used for like things like salaries, outside of 10%, or other kind of opportunities that's specifically bonus focused. So so I think presenter incentive, that's kind of like that general term, like look at it as like a bonus. So if you have individuals in your facility that you want to really encourage to become preceptors, that are just, individuals that you want to support and then have them lead, you can offer them the bonus as like a kind of a parameter around, hey, we want to offer you a retention bonus. Part of that is if you're interested in becoming a preceptor, you can have this bonus. Otherwise, there might be others that are interested that you can use that on. So there's the flexibility. We want to give you the flexibility to really design that to your needs. So if you don't need clinical training capacity, you don't have to use it as a bonus for encouraging preceptorship. But if you do, it's available and optional for you to use. It's just, again, the terminology that we're calling it a retention bonus or recruitment bonus, but it can be used to give a bonus to an individual to have them do that work as well. It's just, again, there's the 5 obligation and tracking, and then they're working full time. But we do want to give you the flexibility to build out your needs, but within that bonus structure. So shared staffing pools and regional coordination. All right, that's a good one. That's a tough question. So when we talk about like these shared staffing pools, we know there's organizations out there that are small, that might not need a specific type of provider because they don't have the hours to support that individual. So when we talk about that, we talk about if there's multiple organizations. So there, let's like example I can give is like there's a hospital there, an FQHC, a tribal program, and a rural health clinic. All 4 are there. They're spread apart. They're not like all next to each other. But they all need services. Individually, they might not be able to support it. Together, they can. So if there's a coordinated effort there, again, the collaborative consortium, whatever you'd like to call it, um, if they can coordinate and say, hey, we need this individual, let's say you need a nurse midwife. We need this individual here this many hours this week. This other facility says we need it here. So all of them would get into an agreement on how they can share those resources. To us, that's what we talk about with staffing pools, whether like the parameters and the specifics, and there's probably many more requirements around like contracts, things like that. That's really for the organization applying to kind of work through with their partners. But what we're saying when we say regional staffing pools is, again, having that provider that community needs and organizing and coordinating together with multiple sites to ensure how you're going to have that provider have their hours, be supported, and work there. So that's kind of, I don't know if that's, so you probably want a more specific answer. So please feel free to give us an email on this. But generally, when we talk about shared structures, and the regional coordination, again, is very specific to like that central facility, whether it's a hospital, and then the supporting facilities when there's like things like specialty care or services needed. There's definitions within that for regional coordination, as well as scheduling infrastructure. It's all around like the multiple sites together working to support each other. Next question, and this looks like a good one too. So I'm a 501(c)(3) workforce organization headquartered in SF. We have a statewide presence and plan to partner with a healthcare consortium in the Central Valley. Is my organization eligible to be lead applicant on behalf of the consortium partnership since we have active SAMSTEDs? So good question. So this is more like consortium model. So yeah, a consortium does not necessarily have to be physically located in a rural community. All the participating organizations, so facilities do, uh, and they have to have sites in rural facilities, and the providers that are getting the bonuses have to be. So there's no requirement that the organization itself that's going to be like, well, you could look at it almost like an administrative partner that's going to oversee the funding for those multiple facilities. There's no requirement they're located in a rural facility. They still have the same parameters as far as the program costs, and then the requirements of that each site within the application has to be in a rural site. Yes, the quick answer is you don't have to be in a rural site if you're like that supporting entity over the multiple sites. Hope that answers that question. Does a qualifying application need to include recruitment retention bonuses? Or I think this question already came up. It's about does it have to include bonuses or can it be other activities? So it does have to include bonuses. Like I mentioned earlier, if you're doing preceptors, things like that, you can use bonuses as like encouraging preceptorship. But in general, the actual funding itself has to be given to providers as retention and recruitment bonuses to provide services in those communities. Do you provide a template for the agreements with the health professionals? I believe we don't. We have a grant agreement, and that has some parameters around like the agreements that sites should have with the provider they hire or retain. But we don't have a template for individual organization to provider contracts. So if you want to email us separately and ask us more detailed questions about that, but generally we leave that up to the organization to structure. And we do give parameters, like I said, in our grant guide, what they should have as far as the obligation and the payment structure. But just beyond that, we don't give like the details on how the contract should be between providers and their organizations. If your organization serves multiple rural communities, can we be included as a subrecipient on more than one application under different clinical partners in different counties? Are there limitations on CBO participating? So I think that was probably more related to that previous question too. So you can apply through multiple communities, multiple applications, as long as you're not duplicating the sites and the providers. So if you're in, let's say you're in Modoc County, but you're also in Sierra County, if you're applying and you would apply through each, whether it's a collaborative or organization, you can apply through multiple streams. Again, just want to confirm, if you're applying from one location, it wouldn't be like multiple applications through multiple consortiums for the same exact sites and providers. So just want to confirm. So yes, you can apply through multiple consortiums as long as you're not duplicating. Let's see. Any other questions coming up here? Let's see. More coming in. So the team is furiously working. I know there's a lot of questions I see on the Q&A. So hopefully we have about 10 more minutes. So I want to be able to address as much as I can. I want to also reiterate, most likely based on the number of questions I've seen, we probably won't be able to address all of them. I know there's many being answered with the team itself, and I'm trying to answer as many as possible. If we run out of time, what we will do is please send your question in to info@calruralhealth.org, and we will give you a response within 24 to 48 hours. So just want to make sure. So yeah, again, there's many questions. Probably won't be able, we probably won't have enough time to answer them all. Trying to address as many as I can. But if we don't get to your question, please do send it to us because we really do want to make sure everyone's informed as much as possible so that we have the optimal use and most highest quality applications for this grant. It's really important for us to make sure everyone is supported here. So next question, if a provider commits to a 5-year service obligation but leaves after 3 years due to unforeseen circumstances, what happens to the recruitment retention incentive? Can the position be backfilled while retaining the remaining grant funding, or will the organization be required to repay the funds associated with that provider? It's a good question. So luckily, because it's in arrears, if someone does leave, let's say after 3 years, they would have been paid for the 3 years they served. The 2 years comes back. Now it's very dependent on what phase we're on in the overall rural health transformation program. The program ends in 5 years. So the funds can't be kept past a certain point. So if you're not able to use those funds and we still have time, we could think through like potential ways of like reallocating those funds. Again, what gets tricky is that if it goes to another individual, that's now a new 5-year obligation, and it might not meet the timelines that we have set with CMS for when the grant actually ends with them. Uh, so it's probably a more nuanced question of like, yes, you can keep it and use it, or no, you can't. If it's relatively short, let's say someone finishes in the first year, then we could definitely like work with you and see like what if there's opportunities to move that funding and bonus to someone else. Um, but if it's within a certain time frame where it's just not enough time to then expend those funds and move them somewhere else and have someone work through the 5-year obligation, uh, then that's a little more challenging, and that's where potentially the funds might have to come back. But again, that's probably more nuanced, and it's not just like a clear cut yes or no. Um, but in general, again, if it's early enough, we can work with you to figure out like how you can use that fund for other providers. So next question, I see there's a 150K maximum. Are there amounts different for each professional level, such as 150K for physicians and lesser for doulas, MAs? If yes, how do we find those? So that is an up to amount. So we really are, again, always talk about flexibility for this program. We really want to leave it up to the organizations applying to best understand what their workforce needs and what the amount they want to set. 150 is a maximum. Obviously, we look at it, we say like there's some parameters in the grant guide saying look at the overall workforce, labor demand market, existing kind of salaries, and understanding that if you give the same amount to everyone regardless of level, that there could be questions around like how does that exactly work, and obviously one's more beneficial to one type of workforce than the other. So it's really based on what you want to provide to individuals. So you can have a lesser amount, a smaller amount for staff that are whether they're depending on the degree and profession and scope level, and a maximum amount for say someone like a physician or a nurse practitioner or a PA. It's really based on what your need is. You can even offer something beyond like what you would might think is a lower amount for support staff because it's someone that you desperately need and you need someone to work there. It's entirely up to you. We try to offer is uh, be thoughtful, be considerate of who's getting the award and the amounts, and be compensated with like what current levels are of the salary. So address it how you think is best for your fit. But again, we do recommend like just being thoughtful about how high of a level you provide to each provider, but it's really entirely up to you. Can the project focus only on certified positions such as those and CHWs, but not clinical professionals? Yeah, you can focus the request for funding to whatever professions you prefer. You can see it in the structure of how we kind of structure the priorities. Again, doulas are a priority because they're in that maternity care. CHWs, depending on which what they're focused on supporting, again as well. So it doesn't have to be like you don't have to have advanced providers. You can say we solely want to focus on those non-certified professionals and entry-level folks. As long as they're part of that team, that's fine. It's really entirely based on what your need is for your facility and your community. Um, so let's see next. Can the project? Oh, we already answered that one. Okay, so and we actually everyone's telling me we have a little bit more time, so um, we're going to 2:15. So good news, everyone. You get to hear me for another 15 minutes answering questions. So happy to kind of keep going through these as I get them. So next question. This is related to a collaborative or consortium. Can you recruit additional partners once awarded? We work with employers and we assist with training. We would want to recruit additional employers and have existing partnerships with these employers, but I'm sure we can secure agreements within the next 30 days. That's a good question. I don't know if I have a very like clean answer for that. We do because we score based on who's applying and the sites and the professions. Um, we do want to be very specific that like that's who's eligible and that's who's going to get the funds. If later on you're potentially saying, hey, we want to bring this partner in, what I would say is in the grant application, uh, cite that you have additional partners you want to bring in. If you have the listings of who they are, identify them, and then once we go through the program, we can go contact you and kind of work through your work plan and initiative to see if it's feasible or not. Again, it's all about the timing as well. So if it's something where you don't have that partner identified now, but in 2 or 3 months you might, please list them. Identify that you're going to be working in the next couple of months to really bring together an MOU or whatever kind of agreement you have to bring in new facilities. Uh, but but for more like kind of direct, that's one that you might want to like contact us on separately. But I would say If it's within a certain amount of time, I think we're flexible, but we really want to be, but you want to mention that in your grant application. It wouldn't be something that would come up after we sign the agreement and everything's all set. So next question, if we have a mobile unit that provides service in a rural area, can we apply? So mobile unit, you can apply. It has to be only going to rural communities, and it should have a central location as well. So I know many mobile units potentially are connected to whether it's a hospital or facility. So we want to know what facility or hospital that's connected to. But it also it's additional tracking because we'd want to know the where the providers are going and which communities they're serving in. So we'd have to know additionally much more information on like where those services were provided, so we can ensure that it's provided in those rural communities. But yes, they could be part of the larger application. Okay, let's see if we have any other, I'm gonna get some more additional questions, and I'll try to like make sure I get them. So next question. If we have multiple rural sites within our service area, can we apply for the grant for each site, or can we apply once for our organization? So that is actually something that we leave entirely up to you. You can apply as one organization with multiple sites that you want to have share the funding with. Something like that would be like the 2 million cap. You can also apply individually for each site. Uh, it's almost one of those things where it's like apply at your own risk because there's no guarantee each site will get awarded. But if you apply as one system or consortium or organization, uh, and that gets awarded, that means all the sites have the opportunity to use those funds. So there's a little bit nuance there too, but it's really up to you to make this like kind of think through and decide uh, what should I apply for each, risking that not every one of them might get an award, or do I apply as one, where the likelihood of getting something for everybody is much more likely. So that's really kind of based on you as the applicant wanting to decide, but you can do it either way. It's really your call there on what you think is most beneficial for you. Next question, if is a health workforce delivery consortium made up of health providers like a hospital association, individual hospitals, FQHCs, not-for-profits, and academic representatives eligible to apply for the grant in a lead role? So there are no specific, as far as I remember, and someone might put in the chat if there's specific requirements around what a consortium is. But really, what we're looking at is that to me is more like almost like a third party. I don't call it a third party entity, kind of supporting the infrastructure of the administration of the grant and getting the funds out. In that case, yes. So an organization that doesn't necessarily provide those services can apply on behalf of the facilities that are getting the funding, but it has to be clearly outlined, the structure in the application, that the funds are only going to the rural facilities and rural providers. Again, minus the 10% if it's like an administrative thing. But so yeah, you could have an organization applying that necessarily is not like a facility or a clinic. But we do ask in the grant application for whether it's like the agreements in place between those organizations on that entity has the ability to administer it, to provide funding. There are requirements for like the structure of that organization and how it's interacting with the facilities. But ultimately, if it's an organization that wants to kind of be like that hub to support multiple facilities and rural communities, that's allowable. Again, with the restrictions that only those rural facilities are the ones getting funding. Are not-for-profit organizations eligible to apply for the lead role? I don't see them mentioned in there. So again, similar question. So if you're an organization that's kind of leading the effort and are like the administrative partner and coordinator, that's great. But again, the requirements are that within that application, you have to list rural facilities and rural providers as who's getting the funds. Bonuses cannot be going to anyone else besides those facilities. Next question. Can you clarify the eligibility of independent private clinics in designated rural areas? Are they able to apply as the rural applicant? Similarly, are they able to apply as part of a collaborative, assuming they are not designated community health centers or lookalikes? So private clinics can apply. There is a category in the application for a comprehensive clinic. That could be whether it's private or not-profit or public. They are eligible to apply. Again, it's really focused on what their needs are, what they're requesting, but they are not excluded. And same with a collaborative. If we have private facilities as part of a collaborative, that's great. Our intent really is to create these collaboratives across the community and the region, and hopefully not to exclude anyone, so that everyone's working together cohesively, because that's when you really get the change and the impact you want in those communities. So definitely yes, if it's a small organization, private facility, they can be part of a collaborative. There's no restrictions that don't allow that. Let's see, next question. We have a collaboration with FQHCs to participate in a 12-month transition to practice NP and PA fellowship where we provide advanced training, but they employ the NPs and PAs. So can this model fit in this grant? We offer expanded training for APPs and preceptors. So this goes back to how you want to use those bonus payments. So uh, in this case, again, it's not these bonus payments are not necessarily specific to give to individuals who are in a training program or going through a fellowship. It's for individuals that are have their full ability to practice under whether it's a license certification or a non-certified role. Um, so in this situation, they would have to be a fully functioning practicing provider in that location. And if the bonus is, if at the same time they're practicing and going through a fellowship, which I don't know how many of those exist, that's a different potential story. We have to probably talk through that with you a little bit more. But overall, the bonuses are not necessarily to fund folks in existing training programs or fellowships. Uh, they're to support the staff that are either working there directly, providing services, or to support, again, like we mentioned earlier, to support bonuses to folks that want to potentially be preceptors. So they're offering the trainings. So I don't know if that directly answers the question, but just want to ensure, yeah, the individual that gets the award, as soon as they get the award, they have to be a fully unrestricted practicing provider in that community at that level. So I don't know if that helps answer the question, but feel free to email us and we could probably get into more nuanced details of that one. What is the time frame to be eligible for retention? Must they hold a specific role? That is entirely up to the applicant. So role is outlined when you apply and you identify which role you want to use the retention bonus for. That is what when we execute a grant agreement with you, that is the role that funding is earmarked for. The eligible time frame again for retention, that's entirely up to you. If it's someone that it's flexible as if you want to focus it on folks that have been there for many, many years or folks that have been there much shorter, but you really need to keep them there. It's entirely up to the applying organization if they want to put any parameters around only individuals in their organization that are eligible or if they work this much time here. That's entirely up to you. We don't have any requirements about whether it's 6 months, 10 years. We want to leave the flexibility up to the applicant so they can decide what's best for them. But the role itself has to be the role that you identified in the grant application. May grant administrative funds be used for legal fees, collection expenses, payroll admin, and monitoring over the 5-year period? Yes on most of that. So payroll, yes. So admin and monitoring over the 5-year period, yes, that's really what that intent is. So if you need staff to kind of track and those individuals, support them, yes. Legal fees is a little more of a gray area. I don't know if I have the direct answer for that, but if you want to email us again, email us at the info email address about some of those requirements around how the fees could be used. Please do. I don't want to say like yes or no on the legal fees because that's probably a little more nuanced of what CMS allows for the expenditures too. Okay, next, are skilled nursing or congregate living health facilities eligible for workforce grants? So it's a good question. So this has come up. So the skilled nursing facilities and other types of facilities that you don't see listed as our eligible facilities or priority facilities. This is where it gets a little challenging. So we want to ensure this initial year. So one thing I want to highlight, this is the year one grant. So the way it's set up right now, the parameters, the requirements is really focused on addressing the initial need that we heard from our partners through our engagement sessions of what's needed right away in year one. As we go through in year two with this grant, we will look at like what we can address and how we can kind of fix some of the issues, questions, and really expand the scope to support others. So in the context of an individual facility like a skilled nurse facility applying, uh, it's most likely not. They would not be able to apply individually. What we say here is we recommend because of the full, the objective here is to initially support these full scope primary care, maternal health, comprehensive facilities. What we'll say is if a skilled nursing facility is part of a collaborative consortium, they definitely can participate. Again, going back to some of those like kind of shared resource models, shared workforce. So if there's opportunities to share resources, share workforce, we do want to see that. We want to see multiple facilities within a region working together. So that's where really the opportunity for skilled nursing or some of the other facility types that you don't necessarily see in our listing can work together. So that is one of the big opportunities there. But again, this is the year one funding and how we're really prioritizing for what we heard from our partners. Year two, we're going to look at what we didn't initially address once we get all the applications and the funds out, and how we can realign the program to really expand and address more services needed in rural communities. And I think, am I getting the hook on that? Is that all the questions, or oh, it looks like we're caught up on all the questions. Let me see if there's anything potentially that might need any clarification or support. Um, so it looks like I might be caught up. So yeah, if anyone has additional questions, it looks like there's some more coming in. So you got me for another 10 minutes, so please fire away with the questions. And I do appreciate everyone taking the time. I know we're over an hour, got a couple more minutes, but it's been fantastic to have everyone here just peppering us with questions. We really want to make sure that we answer them all. And again, please remember, if we don't get to them all, email us and we'll answer them through the email as well. And then we'll also put out FAQs based on some consistent and common questions we get that'll hopefully address that as well. Okay, next question. Can you provide clarification on the answer about applying for multiple sites? Are you saying that if we are an FQHC and we operate 7 sites in rural areas, we can apply for $1 million for each site? Yes, if you choose to apply for each individual site, you can. The risk there is that not every site will get awarded based on the competitive level and other applicants from that area, that community. You can apply as a whole and list all your 7 sites within the one application. That's where that 2 million cap is at. So it's really dependent on what your needs are, and if you want to go ahead and apply individually. Again, letting you know there's a risk because we are looking at who else is applying, distribution geographically, equitable distribution geographically as well. So if there's other applicants from other areas that are within your region and you apply individually, that you might not get it, they might, other folks might. So there's no guarantee if you apply individually that every site will be able to access it. But again, if you apply as one, that's where it's much safer, where everyone will. So really, it's dependent on what your approach is and kind of your priorities for where the needs are the greatest. So the next question, for a retention bonus, does the provider have to be employed? If the provider is contracted to provide services, does that meet employment requirements? So I'm assuming this is contracted meaning for physicians or if it's other providers type. So one thing I'll say is physicians, yeah, we understand the nuance there with hospitals can't directly hire some physicians exactly. So uh, as long as there's an agreement between your site and that provider on the obligation terms, they can be contracted. Now there's requirements within the grant guide where we talk about like the larger like entities that do workforce like registries, things like that. That's where it gets a little more nuanced, where we necessarily want to make sure that reliance on those types of services are not hindering providers in certain facilities. So that's where we want to say those type of things where uh, physicians is one aspect, which is much more like understandable. If it's a group that's being hired through this a national registry or something like that, that's where we're less hesitant to say yes, you can contract with those folks and they get the bonuses. It's really we want to have you make sure you have a provider at your facility that's your provider working for you directly and not coming through a hiring agency or something like that. Can we work with educational partners out of state? MODOC borders Oregon and Nevada, and we have no local California community college or universities. Our closest universities are in Klamath Falls, Oregon, and Reno, Nevada. So um, I wonder that might be probably more related to maybe the training capacity. So as far as bonuses, again, that I don't think that really relates to the bonuses. But if you're working with educational institutions to expand your clinical training, those again the funds we have here with the rural health transformation necessarily wouldn't be used to provide funding to those educational partners, so it might not necessarily be a risk. There will be later on. There's much more programs that are probably going to come up where this question is probably more relevant as far as education and training goes. But in this situation, unless I'm missing something here, if you want to give us like a more specific question, an educational partner necessarily wouldn't benefit from this recruitment retention bonus unless you're talking about something like faculty, which in that case, if you're giving a bonus to have faculty work there, that's allowable. It's not necessarily, the funding has to go to the individual. It's not going to an organization. So that's where, again, it's probably a little more nuanced than I'm probably explaining, so feel free to email us. But generally, that situation shouldn't come up with educational partners because they're not directly providing services at your clinic, at your facility with that provider. Can a rural hospital in bankruptcy be included in a consortium application? Well, that's a good question. Really, it's a lot of interesting questions coming up today. So that would be something for the consortium to decide. Ideally, there's a risk if the hospital is going to take in funds with obligations and they shut down. What happens then? But it's a risk that the consortium should be identifying. It's not something that we've provided like direct a response to yet. But it's something that, thanks for that question, because it's actually something that you need to think about now. But ideally, this is something where the consortium would identify it because the risk there is that the consortium itself would be responsible for recouping those funds should that facility then shut down and close down and the providers don't have anywhere to go. So it's the call on the consortium. But again, contact us if that's the situation because we want to be able to work through that, identify what risks there are for you on that one. Will future years provide funding over several years, or will applicants be on a year-to-year basis over the 5 years of the RHT funding? So there will be future application cycles. Right now, the way it's structured, and it's explained in the grant guide and grant agreement as well, is the funding is given to the organization, the facility, the consortium. They would pay the provider in arrears, but that funding is intended to go over 5 years. So the grant agreement you'll get will highlight that. But again, it's almost, you can see it as a year to year when you're applying for the grant, but when you get the funding, you have those 5 years to award it to the individuals in arrears because again, we want to minimize that risk. So if you apply next year for the similar program for the different providers, same thing. You would get the same structure depending on if the program is exactly the same or not, but the funding is to provide in arrears over 5 years to those individuals. Next question. How would the organizations use funds to pay for training if funds can't be used for third-party contractors, such as outside trainers? So it's not necessarily paying for the funds for training. This is where I think there's some nuances here. This is the initial step to really expand clinical training capacity. So we talk about using these bonuses for like preceptors. So having it set up so in year 2 when we start funding training programs, training opportunities, that's where I think it connects much more to like these outside entities. You'll have the infrastructure in place with folks that are willing to be those preceptors, faculty, and trainers. So it's not necessarily saying, hey, use these funds to train them now. It's to describe to us how you're going to use the funds to start expanding the capacity. So in year 2, when we start awarding these clinical training capacity grants or education grants, you're set up to just right away integrate into that system and have clinical training at your facility or expand it into your facility. Next question. I think this might be the last one because I think we're getting close to time. Our understanding is that the letters of support for participating partners are required, but the application system does not allow us to upload letters from an organization that are not part of the proposal. Can HCAI clarify whether letters from elected officials or other participating groups would be considered valuable? And if so, how should we submit them? This is something I actually defer if someone has a response to type in this one for as far as the letter support. I know if you're a collaborative or consortium applying, there does have to be letters of whether it's an MOU or letters of agreement, letters of support from all the entities participating, saying that they are dedicated and focused and aligned on supporting this program. Outside letters of support generally for this program might not be necessary because it is more we're looking at this more on data focus with the criteria and the scoring. So letters of support are less likely to really support in this situation for letters of support that are people outside the applicant pool. So outside of the consortium facilities that are supported. If it's a public facility, there's this whole separate process where we need a letter from the governing body, and that's outlined in the grant agreement as well, highlighting what's needed from you if you're a public facility to ensure that you can spend the funds and you can accept the funds. But just like a general letter of support that some grants require for folks that are like, associations or groups like that within that area, that's not necessarily required. But I don't know if the team has a specific answer because I don't know if that necessarily in the portal itself has it set up to accept outside of the regular application letters work. And last question. So if a provider transfers from one rural clinic to another in the same organization, are their funds uninterrupted? What if they transfer from one org to another but remain in rural? Are they eligible for a new org? Great question. So if they're going within your system or within the facilities that are identified in the original grant application, completely fine, as long as they maintain that rural status. Um, if it's a site that's not in the original application, that's something we might have to talk through because what happens then is they no longer are part. They then break their obligation from your organization and then go to that new site, new organization. So in that case, a new obligation contract would be required between the participating site and that provider. So there is a transferability if someone moves to a different location. The requirement still is that they have to be in a rural community. That's the one and only like hard and steadfast requirement that we've probably been hearing us say a lot. They have to continue to be serving a rural community. If they move, that's where there's flexibility to assign the obligation to a new organization. If it's within the applicant consortium and it was listed, that's fine. They can move around. We just need to make sure that's still being tracked and the obligation agreement is still intact with whoever their employer is now. And that's all the questions. I think there's probably many more that we didn't get to answer. So again, please submit your any questions that we weren't able to answer to our mailbox, and we'll address them as quickly as we can. I do want to thank everybody. Really appreciate the time today. Hope everyone got what they needed. But if you didn't, please again contact us and email us and let us know what you need from us and what questions you have. Thank you, everybody.